thyroid scan, we'll be discussing much more in congenital hypothyroidism as well as thyrotoxicosis. But brief word is that when you do thyroid scan, basically you are picking up the radionuclear uptake, which is happening. And there are two agents which have been used, iodine 123 as well as technetium 99. You do not recommend I-131 because it is ionizing, it causes radiation, it is not preferred. Technetium is generally considered to be the standard test in that regards. Now, to pick it up, you need to have the sodium iodine importer, you need to have a TSH activity, and that is why we said that you should either have stopped thyroxine or you would have given TSH before doing the test in that setting. Now, radionuclide choice, the options are technetium, which has got a shorter half-life, but it does not give you information about organification. It just says that it is taken up. It is of no role as far as perchlorate test, but your result will be very quick. Small child, send them, they will give you a result in half an hour, 1 hour, and radiation exposure is low. I-123 has a longer half-life. It gives you information about organification. So all the secondary defects and perchlorate discharge tests you can do, but it will take long time and maybe a repeat scan is required. Now, often your patients are on some medication and you want to decide about thyroid scan. So how long should you wait before you do a thyroid scan after methimazole? So 3 to 5 days. And lithium can also have an effect. So 2 days, LT3 definitely 14 days. This is in the setting you're talking about the malignancy where you give thyroxine LT3 and then you wait for 2 weeks. While if it was thyroxine, you need to wait for at least 6 weeks. So this is the difference which is there. So if you have a decreased uptake in the setting of hypothyroidism, you're dealing with athyrosis, sodium iodine importer defect, TSH receptor defect, or a TSH receptor blocking antibody. So you will have a true versus apparent athyrosis. Get a thyroglobulin or an ultrasound done to differentiate in that scenario. Now, in the setting of thyrotoxicosis, if there is autoimmune, subacute, or acute thyroiditis, your uptake will be decreased in that regards. Uptake will be increased in hypothyroidism because of autoimmune thyroiditis also. Regional patchy uptake may be increased. And of course, in dysharmonogenesis in congenital. In thyrotoxicosis, of course, the TRAb level is high. Your uptake will be more in the setting of Graves' disease. So thyroid scan is done for congenital hypothyroidism, thyrotoxicosis, and follow-up of thyroid cancer. Of course, this requires, it gives you information about site and function. You've got iodine 123, but technetium is more commonly used. In small children, you do it after feeding. Why?
So that
they can sleep.
Yeah. Salivary gland will also concentrate this, so the secretion will be more.
Yes, so good. So if you have a stimulated salivary gland, you will lose the concentration of iodine. Otherwise, falsely positive, they will be regulated there. It should be done ideally before treatment, but if your TSH is about 30, you don't need to worry. Often people say, okay, his TSH was 1000, somebody started thyroxine 2 days ago, we don't want to do a scan because treatment started. No, you can do it till the TSH is more than 30. And of course, in 2 days, you don't expect the TSH to really go down to that level. And if you are in doubt, you can do it after 3 years once you have stopped the treatment. And we'll discuss this more in terms of congenital hypothyroidism. So you may have no gland, you may have an ectopic thyroid, and scan is the best test for ectopic thyroid. Ultrasound may not give you idea. You may have a hemiagenesis or you may have a dysharmonogenesis in that perspective. Perchlorate discharge test was being done earlier to look at organification defects. It's negative in thyroglobulin or pendrin, positive in sodium iodine importer and TPO. It's not being done routinely. The role predominantly is that if you have a borderline TSH in a transient scenario, you can look for in that regards. So athyrosis can be because of the thyroid gland defect, but you can also have apparent athyrosis, as I said, because of a sodium iodine importer defect, a TSH receptor defect, or a TSH receptor antibody. So anybody who has an absent thyroid scan does not mean that he doesn't have a thyroid. Do an ultrasound and thyroglobulin. So apparent can happen in sodium iodine importer defect, in TSH receptor defect, or TSH receptor antibody in that regards. We'll discuss about thyroid ultrasound much more when we talk about solitary nodule. but it gives you a lot of information about the thyroid gland, the isthmus, look at the vascularity, look at the lymph nodes which are there in that perspective. Now, one indication in which thyroid ultrasound is often done is into the setting of a congenital hypothyroidism. But many pediatricians ask that their radiologist is not very good and they may not pick up the thyroid in the newborn period. So what is your message to them?
They are more like adrenal and thyroid. Generally, they have to be picked up in the newborn period because the size is quite
So
large.
uterus,
Uterus, adrenal.
adrenal and thyroid are big in children. So if it's not there, it's not there generally. It's very, very difficult to miss them. Let's put it that way. So don't go that, okay, your expertise is less, you won't be able to pick up. So thyroid is bigger at this related. Of course, if you're looking at finer things like thyroid scoring, if you're looking at particular other thing, then it's operator dependent. But otherwise, you need to be very careful. It, of course, has limited role in ectopic and it gives you more morphological rather than functional information. So if you combine scan and ultrasound, you can really identify a lot of these diagnoses from that perspective. In thyrotoxicosis, as I said, you will get information, especially, you don't need to do it in everybody. You can do it in somebody who has got no eye sign and no goiter, or if you have a toxic nodule. So you may have no uptake, which is thyroiditis. You may have bilateral diffuse uptake, which is Graves' disease. You can have a toxic nodule, and you can also have a cold nodule, Dhwani. So what is cold nodule?
This one where the uptake is minimum and the rest of the gland is normal.
Yes. And warm nodule?
Warm is the nodule will be hot, but the remaining area will not be suppressed. It will also show.
This is very important. So if you have a toxic nodule, if you see, other area is zero. If you have a toxic MNG, again the same picture. If you have a cold nodule, everything else is picked up. The nodule is not there. It's a very, very bad sign, a high risk of malignancy. Similarly, if you have a warm nodule, which means you have got a more uptake compared to the background, but there's still a background uptake. That would basically mean that there is a risk of malignancy. You need to do an FNAC out there. The nuclear scan, of course, if you don't have eye sign, you can avoid it. Increase uptake, you can have solitary nodule, you can have toxic MNG or Graves. If it's decreased uptake, think of thyroiditis as a possibility. Solitary nodule, as I said, this is a typical autonomous nodule. No need for FNA. This is a cold nodule. What are you seeing here is that these areas are black, uptake is there. This area is a filling defect. So it is a cold nodule and FNA is required. And very importantly, in certain scenarios, if there is a doubt, they even say iodine is better in nodule evaluation compared to technetium. Now, the other thing to remember is that you may have an intermediate nodule in which you will have a warm nodule. Now, very importantly, when you're looking at scan, it's a two-dimensional picture and not a three-dimensional picture. What is its implication then? It's a two-dimensional image rather than a three-dimensional. So suppose you have a deep nodule. So you may actually be missing that deep nodule because this area you will say, okay, uptake is there. It's like a picture. So upper area, the uptake is there, you will falsely miss that. So this is something there. So ultrasound will give you a better picture when you're looking at in terms of the posterior nodule in that regard. So small, less functional FNA will be required.